Okie doke. I've got it at 2 o'clock, so welcome and hello everybody, and welcome to the second online forum for the Refugee Nurses of Australia National Forum 2020. Thank you for joining us today. Hopefully some of you are able to join us for our first presentation. We've had some very good feedback about that. And again, I'd just like to start today's proceedings by paying my respects to the local Indigenous people here in Liverpool. That's the Gadigal people of the Eora Nation. I pay my respects to their elders past, present and emerging. So today we have a different theme. We're going to explore a couple of different models of care that we do around Australia, and our first speakers today, I'm delighted to introduce Meryl Jones and Nancy Weatherford from the Mater Hospital in Brisbane. And they're going to be speaking to you about their GP collaborative model of care, and that will be followed by capacity building in primary care, and that is with Nyari Garak, sorry, I've put them around the wrong way, haven't I? So Nyari Garakasha, who's a clinical nurse specialist in the Illawarra Area Health Service, local health district here in New South Wales. So for people online, if you would like to ask a question, you should be able to see the Q&A function at the bottom of the screen there. So we do ask that you pop your questions into there, and we'll make, so we have advised our speakers, discussed with our speakers, that we do need to make some time for Q&A. And just to remind people too that this session is being recorded, and that the recordings will be available later through the Refugee Nurses of Australia website. And I would like to also thank the Ingham Institute, who is graciously hosting us again today. So I would like to acknowledge and pay my thanks to them for all their technical support. So without any further ado, we'll have get Meryl and Nancy to start us off. And that's Meryl, if you'd like to join your screen, share your screen, and away you go.
Oh, that's better. All right, so thank you everybody. So Sammy said, my name is Meryl. I'm the Nurse Unit Manager of the Mater Refugee Health Service here in Brisbane, and Nancy is one of our clinical nurses. And we're going to be talking to you today about our model of care and how we build capacity in primary care. So we'd also like to acknowledge the traditional custodians of the land that we're on today, which is the land of the Yagara and Turrbal people, and pay our respects to elders past, present and emerging, and also acknowledge that sovereignty was never ceded. So our service sees the majority of new humanitarian arrivals who come to Brisbane every year, and to put that into context, Brisbane receives about 850 humanitarian entrants per year, and under our model of care, newly arrived refugees are referred to general practices in the community in areas of high settlement, and when they're in those practices, both the practice and the patients are supported by a co-located specialist refugee health nurse from our team. So in this presentation, we're going to talk a little bit more about how this model is achieved, how we actually identify and engage with the practices that we work with, how we upskill the teams in those practices, and also how we build capacity more broadly across the primary care sector. So it wouldn't be possible to achieve the model that we have without extensive partnerships and collaboration. And you can see on the slide there some of the different organisations that we partner with. So our service, the Mater Integrated Refugee Health Service, is state funded, so we're block funded by Queensland Health to provide health assessments for refugees settled in the Brisbane North and South areas. So we partner with Multicultural Australia, who are the Queensland HSP provider, and they refer new arrivals to our service so that we can link them to an accessible GP practice in the community to have their refugee health assessment started within 28 days of their arrival in Australia, which obviously is the KPI that the HSP provider has to adhere to. So we also partner with the primary health networks, or PHNs, from Brisbane North and Brisbane South to identify the practices that we'd like to work with, and also to help us disseminate resources across practices. The Refugee Health Network of Queensland convenes advisory groups and working groups, like the clinical advisory groups and working groups on mental health, oral health, and they provide guidance to all health professionals providing care to people of refugee background across Queensland, and obviously that includes our service as well. So this slightly complicated looking infographic actually sort of illustrates the journey of new arrivals with our service. So usually we engage with newly arrived people for about 6 months after their arrival in Australia, which usually coincides with the time that their catch-up vaccines are complete. But we do have the flexibility to provide ongoing support for people with more complex needs. So over here on the left-hand side of the screen, you can see what happens before people arrive. So Multicultural Australia provides us with families' HAP IDs. So then obviously we go in and we review the visa medicals and the departure health checks. And we make recommendations and arrangements for people to access care they need from the time that they arrive in the country. So when people have arrived, so just over here where the little aeroplane is, Multicultural Australia then tells us the address of the family where they're living and tells us about any health needs that have been identified by settlement workers on arrival, so we can help to make any referrals or appointments that are needed at that point. And then Refugee Health Connect is a partnership between our service, the primary health networks, and the settlement agency. And we meet every week. And in those meetings, we work out which practice we're going to refer each case to. Our admin team makes the appointments for those first visits for health assessments and provides the GP practice with the person's demographic information, including obviously the need for an interpreter and what language, the health information that we've downloaded from HAP, and anything else that they might need to know before the appointment. And then the Multicultural Australia Health Coordinator makes sure that this information is communicated back to the family via their case manager and makes sure that the family don't have any other conflicting appointments on the same day. This also actually gives you an idea of the spread of practices that we work with. So for anybody who's particularly familiar with Brisbane geography, it's actually, I think it's about a 71-kilometre distance from north to south is the area that we cover. And obviously the practices represent areas where newly arrived refugees are settled in Brisbane. So we do acknowledge that accessibility of a practice is not always about geographic proximity. So obviously we take physical accessibility into account, but also economic and cultural factors. So finding geographically placed practices that are near to where people are living isn't always particularly practical or easy, especially when we're trying to meet the HSP program's 28-day KPI. We do try to look for new practices in areas where the settlement agency are placing newly arrived refugees, particularly if people are being placed in suburbs where we haven't, where people haven't been settled previously, or sometimes also if there's very high levels of settlement in a particular area, so that we can load share between practices and make shere that nowhere gets overloaded or burnt out. We look at public transport routes. because sometimes a practice that's actually in the same suburb as where people are living might not actually be as easy to get to on public transport as a practice in the next suburb over. Importantly, obviously we take consumer choice into account. So if we hear via the HSP provider that a family wants to be linked to a specific practice, then we'll try and work with that practice. And we also consider cultural accessibility. So if there's a GP at a practice that we work with who speaks the same language as a family, then we'll try and link them to that GP. So many of you may well already be familiar with practice checklists about being refugee friendly or refugee ready or being a refugee health ready practice. I know that these guidelines are in use obviously within Queensland, but they also exist in Melbourne and Sydney as well. There are key themes across all of these different practice checklists, including data collection, so how you identify patients of refugee background within your practice, identifying interpreting use, making sure that you coordinate care with case managers, using refugee-specific relevant referral pathways, and also providing or recommending that staff have professional development in refugee health. There are specific additional items noted on the Queensland checklist, which are mostly practical hints and tips for practices. So recording details about TIS interpreters used, recommending that practices have a portable speakerphone, encouraging practices to bulk bill in recognition of financial hardship for newly arrived refugees, encouraging them to record all vaccines given onto air, even for adults as well, highlighting strategies to reduce fail to attend rates, and also recognising the risk of vicarious trauma to staff within the practice as well. And we do very much try and take a whole of practice approach. So we provide resources and upskilling, not just for the GPs or the practice nurses, but also for the admin staff as well, because we recognise that they play a really key role. So we try and do regular practice visits. So either we visit practices that we haven't previously had contact with to provide them with resources, and also find out whether they would be interested in working with us to provide health assessments and ongoing care for new arrivals, and also having a refugee health nurse from our service co-locate with them. So the initial approach to a new practice, to their practice owner or practice manager or lead GP, is made by the Primary Health Network. So each PHN has practice liaison officers who have a particular patch, and they can actually provide us with practical advice on the cultural fit of the practice. So are they a private billing or a bulk billing practice? Do they have any language or any staff who speak other languages, that kind of thing? And they also make the initial approach to book a meeting with the practice. And they usually come with us on practice visits as well to sort of introduce everybody. So normally when we go on practice visits, we take the multicultural officer from the Primary Health Network and a representative from our service. So that could be me, it could be one of our clinical nurses, or it could be our director. We also try and do regular annual catch-up practice visits with all the practices that we have working together agreements with. So we can just check in, see how things are going, and also update them on new resources and models of care. So in terms of sort of how we make this happen and the legals behind it, which is not super exciting for everybody, but kind of a necessary thing that needs to happen, we have working together agreements with the practices where our nurses co-locate, and these are signed between our service and the practice. And they're just to make sure that everybody agrees to and follows a set of explicit shared expectations so that everybody in the team can collaborate effectively, and everybody shares a sense of ownership and responsibility for the quality of the interactions within our team. So the working together agreements cover things like how referrals from our service to theirs will be managed, an agreement that our nurses will enter patient clinical information into the medical record at the practice. So the nursing assessments that our nurses do belong to the practice, and they're in the patient's medical record within the practice and stay there. But we do ask that the practice agrees to share data with our service so that we can enable quality improvement and research activities. The WTA has also outlined the roles and responsibilities for each organisation involved and the staff members. So the practice manager, our nurse, the GPs. And our nurse works under the clinical governance of the treating GP in the practice and obviously is bound by confidentiality. The agreements also describe the activities that are going to be undertaken. So, for example, our nurse will do nursing assessments, provide immunisations, and the practice admin staff are responsible for managing patient appointment bookings and also responsible for booking interpreters. They also finally set times for the activities to occur. So, for example, the practice wants a nurse to attend every Wednesday, so they're going to make a room and a computer available for us on that day. So the other level of clinical governance that we have a statewide clinical advisory group, which is auspiced by Brisbane South Primary Health Network. So over the years, so GPs from several practices where we co-locate have been part of this clinical advisory group. And also, because it's statewide, we have GPs and refugee health nurses from other Queensland settlement locations represented on that group as well. So it's got a really good broad membership. The group reviews documents, so things like the refugee-friendly practice checklist. We look at clinical guidelines as well, but also we organise education evenings, which are actually aimed at health professionals working with people of refugee background, and they are specifically aimed at people working in primary care. We usually, under normal circumstances, we try and run 4 events per year on a range of topics. So last year we did mental health, infectious diseases, child health and women's health. And the Brisbane North and South PHNs also fund clinical lead GPs and an immunisation nurse. So they can also do separate practice visits to provide peer support around refugee health for GPs and practice staff. And the Refugee Health Network Clinical Fellow can also do these. So I'm going to hand over to Nancy now. So that's kind of the background behind it. Nancy now is going to talk more about what this actually looks like on the ground in practice.
Thanks. All right, so to start with, just carrying on, this is just a bit of a guide as to the resources that we provide our GP practices with. So obviously, as Meryl mentioned, we are trying to incorporate not just GPs, but the full staff cohort at the practice. The ASA guidelines, the resources we guide them to on the Refugee Network website. We really try and take a whole of practice approach to provide resources and peer support right across the board, upskilling everyone in the practice to provide quality patient care. So I think most of us probably utilise guidelines like that. So then moving on to the practicalities of engagement. I guess this is where we get down to the nitty-gritty. So in the conversations had during the development of the working together agreement and finding the right practice that sort of ticks all the boxes, we then need to get down to the day-to-day sort of stuff. So finding a suitable day for the clinic, for you to join the team, accounting for space like a consult room, a computer, printer, phone, and space for your patients. Often this is not the busiest day of the week. In fact, the slowest day of the week would probably be better if there is such a thing in GP land. You want the team at the GP clinic to be open to and able to learn from you. So if it's a really hectic day, that often makes it very challenging. Regular nurse presence. So obviously if you have consistent arrivals in a geographical area and you've earmarked a clinic to be able to send newly arrived refugees to that clinic, then being able to commit a nurse to weekly or fortnightly, I guess, presence to educate the staff and the patients is much better than a sporadic engagement. many GP staff report back that they have great confidence when they know that the refugee nurse will be back next Monday or next Tuesday. They know that we're coming. Pick a day and then pick a nurse, obviously. Committing to the continuity of staff if you possibly can, and that's obviously getting the same nurse every time is really handy as well. Access and knowledge of practice software. So one of the challenges of working in GP land is the fact that they use very different software to the software that hospital-based nurses use. So typically we might see best practice or medical director being able to utilise that, and for nurses being able to know how to use that and in the full capacity of what it actually incorporates. Utilising that software for data entry, so making sure that social history, relationships, the need for interpreters, allergies, all of those boxes are ticked within that software so that you can really give your patient the most positive experience for them to return to that GP for years to come. Obviously, we know that referrals are automatically generated out of that software a lot of the time now, so to have that information in there, if the refugee nurse has gone ahead and completed that, then that obviously helps the GP out as well as any specialist that might be seen down the line. And then obviously consistent administration support. Despite being a nurse, admin becomes a high priority to you in GP land. So educating admin teams on the importance of the information we get off HapLight, the importance of uploading information to the patient's chart, the use of translated appointment cards, even using a translator to book a recall. Sometimes we have issues with sending of the text message to remind them of the appointment. So just making sure that your admin staff know that if you send a text message in English, then that may well just result in a answer of yes, whether the patient understands the premise of that or not. So upskilling on the job. I guess some of this sounds like it's reinventing the wheel, but lead by example. So from the minute you enter the clinic, be the calm, reassuring voice that you might be on the inside, be on the outside. So obviously lots of things happen in GP land in relation to refugees. Common things might be that extra family members turn up, people don't turn up, fail to attend numbers up, maybe higher than usual. These are all things that we can assist with. So being the example as to how we can deal with these things in a really positive light sometimes is all that they need. Culturally sensitive care, again, I'm sure none of us are really surprised by some of the language that we hear used around Australia in relation to certain groups of people, and I guess leading by example and being overly appropriate, offering that culturally sensitive care and compassion. It's not rocket science, it's basic stuff. Modelling best practice, so the use of interpreters, translated appointment cards, translated patient information, guiding doctors on where to print out relevant translated information for parents of children that might be sick or things like that. There are a huge amount of resources online. It's often just the fact that the doctor has never had time to look, and now you're able to really join the dots in regards to that. Advising on appropriate referral pathways, so using the public health system and other appropriate organisations that you know might be refugee friendly. I said before, if I had $1 for every time a GP referred a patient to a private paediatrician, be on a tropical island. I recognise totally some people are willing and able to pay for this, but does the paediatrician use an interpreter? Are they aware that they're likely to have a family that English isn't their first language? Are they aware that they're likely to have a child that doesn't understand any English at all? Often it can just become a waste of money for the parent, and hopefully you can stop that before it even happens if that's going to be the case. In Queensland, we would consider child health or the child development service. We have, just in relation to paediatrics, we have a lot of options. So just highlighting these things sometimes can just make the difference. Helping with specific processes. So in Queensland, a lot of our nurses in GP land are not immunisation endorsed, and that makes the whole process of immunising and ordering vaccines quite scary. Particularly because these are private businesses. Every GP has, some form of a practice manager and a budget and finances, and the nurses often worried about doing something wrong in this regard. So being able to help clarify how you order vaccines and then how you catch a patient up on vaccines, obviously educating the GP and also the nurse in regards to that. We have some fairly basic catch-up schedules that we utilise and have developed and keep updated, so being able to empower the staff of the GP practice to utilise those as well. And then encourage the use of resources. So we've got some folders that we provide to our clinics for administration, for GPs, for nurses, and just encouraging the staff to be able to utilise those rather than just have them on a shelf, but make them something that's actually a really useful resource. From that point of view, if you've sort of brought all of those things to the front, then you just really need to be present and contactable and build a relationship. I guess this is the part that I actually find the easiest of all. Being friendly, being open, and sharing sort of your day-to-day work life. Sharing your passion. It's no secret. I'm very passionate about refugees settling in Australia and about the global crisis that we have. And I guess I'm happy to talk to anyone at the bus stop or anywhere else about it. So why not share that with a receptionist or with a fellow nurse on lunch? Being able to sit in the tea room and have a coffee, be part of the team, and really just, I guess, just educate through example. Ongoing engagement with GP practices. So obviously it's not just about myself as a nurse or one of the other nurses, but it's about the whole team behind us. So Meryl is a nurse unit manager or the director, the Refugee Network for Queensland. We have a huge range of resources behind us, so it's very much about all of those people being open and contactable by the GP as well, and the GP hearing from them at certain times throughout the year as well. Again, I mentioned private business, so as things change in their world, we just need to keep up with that and be aware of that. And as Meryl stated before, education, we have some great education evenings that happen throughout the year, encouraging your GPs and the staff to attend, and obviously I guess just being aware of the information that's shared at those evenings is really important. So this is sort of how we start to evaluate our outcomes. It's obviously tricky when it comes to data, because we know that we're leaving the patient's notes at the clinic. We just basically want to take the skeleton of that and be able to assess if we're being effective. So this is some of the data that Meryl sort of mentioned. Key sort of points: refugee health assessment, the pathology screen, the immunisation schedule, TB referral, dental referral, and the women's health check. These are all things that we try and make sure every patient is offered at least. And then we can build from there in accordance to, I guess, other factors that might come into play. So our nurses fill out this spreadsheet as a continual, I guess, item in our day-to-day journey. It helps remind us where we're up to with each patient and where we're going from there. This is uploaded then onto ShareFile. So this is one, ShareFile is a cloud-based platform that's actually provided by the Mater Hospital. So that ensures confidentiality with the data, and it means that any nurse can access that from any clinic, any computer, with internet, and should one nurse leave and another nurse take over, then that sort of streamlines that, I guess you could say. And then IPM. So this is just quickly, it's a patient administration tool that our hospital uses for occasions of service. So they use it hospital-wide. And despite the fact that we are not an activity-based service, this is just something we utilise to keep a track on what we're doing out in these GP practices. So the nurse the nurse completes that simple Excel spreadsheet on the left, and then admin type that into the actual database on the right, and should we ever need to pull that data out, we can. And I guess just summarising, we just wanted to mention COVID-19 and the fact that we're very grateful that our model has allowed us to continue on. It's probably one of the biggest benefits of the model so far. So as the pandemic has, I guess, sort of caused some cracks within the health service and within society's function, our relationships with GPs and our patients have continued almost as usual. So adhering to the policies of the GP clinic and obviously local health service, we've been able to carry on with immunisations and referrals. Obviously continuously building that relationship with our GPs and with our patients, which is great. Like most of us, I think our last patients that arrived were arriving into Australia just as COVID exploded. So it's been great to be able to make sure that those patients are heard on their concerns and that we've been able to sort of continue on best we can. So that summarises MERS pretty much.
So, and I think the main thing that we really wanted to share about the model is that we think it really works for patients because the care is provided to people in a really accessible area for them in a practice that's going to welcome them, and that then, you know, after they've finished with us, it continues to be their medical home. So it means that, you know, GP practices across Brisbane now have patients of refugee background who've been attending there for 5 or 6 years, and they're just regular patients at the practice. And the practices are upskilled to cope with them and provide good quality care, and the patients know that the doctors are there for them. So thank you very much.
So excellent. Thanks. Thanks very much. Don't see that we've got any questions down in our question panel there, so we might move on at this point. So thank you again to Meryl and Nancy, and we'll move on to our second speaker of the day. Nyari, if you could just unmute, you're unmuted, and if you could share your screen, and I'd like to introduce Nyari Garakasha, who is a clinical nurse specialist in the Illawarra Shoalhaven Local Health District, and Nyari will be sharing with us today about the change in practice influenced by the stories of newly arrived refugees. Thanks very much, Nyari.
Yeah. Yeah, can you see my screen, Sandy? Hi everyone, my name is Nyari. I'm one of the nurses from the Illawarra and Shoalhaven. Sandy, can you see my screen?
Yes, I can. You just need to start the presentation, Nyari. You're still in.
Oh, I'm not sharing, sorry.
No, you have shared. You just need to go back to slide 1 and start your presentation.
Oh, okay, yeah. Yeah.
There you go. Well done.
Hi, my name is Nyari. So I'm one of the nurses from the Illawarra and Shoalhaven Local Health District. And today I'm going to share with you our presentation entitled Change in Practice Influenced by the Stories of Newly Arrivals in the Illawarra and Shoalhaven. I can totally relate to what Meryl and Nancy were sharing, because it's quite similar to what happens down here, but I was taking a lot of notes as well. So that's really good. So this is just to give you an idea of where we are. We cover quite a huge area. It runs from Helensburgh at the top down to Milton Aladala. So it's really quite a huge area, but most of our clients, they live around here, which is around Wollongong, from Wollongong up to Shell Harbour. That's where most of our clients live. So everyone is familiar with the refugee journey, that it happens in 3 phases: pre-departure phase, travel phase, and the arrival phase. We are all familiar with this, so I'm not going to go into this in detail. But what I just wanted to highlight is our work is here around the arrival phase. And as you can see, there's a lot that happens health-wise in regards to our clients' health, and there's a lot of work that needs to be done. So I just wanted to encourage that, to acknowledge that. So this was a quality improvement project. It started as a project, but now it's a quality improvement initiative. We've decided to do it every 2 years because it's very involving. So what we do is for all the clients who have been here around at least for 6 months, we have interviews with them. We use a variety of data collection. So we use both interviews, and we also give them forms to fill with questions on the forms. And for the interviews, we try and use our casual staff because they will be less biased. And for our interpreters, we try and use the telephone interpreters as well, because it's a huge area to cover, but it's such a small community, so everyone knows everyone down here. So we had 3 questions that we asked to everyone, to all our clients, just trying to find out how they are and how they are going and how we can improve our service. So our 3 main questions were: what was helpful and worked well for you during your health contact with Refugee Health Service? And what was not helpful or did not work well for you during the health contact with Refugee Health Service? What constructive criticism can you offer us so we can improve things? And on that, according to what the client would have answered back, then we use the prompt questions as well, such as: was there anything you expected that did not happen? What were you most concerned about? How did the situation affected you emotionally and physically? And what would you have preferred? How could the situation be changed? What could make a difference? Any ideas on how we could make it better for future refugees arriving in the Illawarra and Shoalhaven? So when we had to make up an action plan to try and gather the data, because there was quite a huge amount of data, and because it was both qualitative and quantitative as well, it took us a long time for us to try and group it into common themes. So we came up with 4 common themes: access to care, respect for patients' values, preference and expressed needs, information and education, emotional support, and alleviation of fear and anxiety. So on the outcomes from the data that we gathered, we got positive and negative feedback. So we'll start with positive feedback that we got from our clients. On access to care, one of the things that they found we are doing really well: home visits, where they found them to be well timed. And of course, we keep the KPI, so we see everyone within 28 days of arrival. And home visits as well, they indicated that it allowed hands-on teaching opportunities for families. So this is a big advantage on ourselves and clients as well, because we have that opportunity for them to go and pick up anything that they would have left in the house, or even to teach them simple things, how to use a toilet. I should highlight as well that a lot of the clients that are resettled in the Illawarra and other regional areas, they come from very disadvantaged communities and quite rural communities as well. Literacy level is very, very low. So everything, they are relearning things. So it's really good for them to be able to show things and clarify things at the same time. Access to refugee health nurse or multicultural health worker was easy. So this is one of the big advantages that we have. We are part of the multicultural health service. So we can actually go for a home visit as a joint home visit with one of the health, the multicultural health officers, and a lot of them, they'll be speaking the language, which actually is good for culture orientation and as a culture broker as well. GP provides continuity and insight into clients' health issues. So the GP here is the main contact for all our clients. Dental care service for children, very quick and easy to access. So the kids, they get all their dental work done within 4 to 6 weeks. And they get the appointment within 2 weeks. So that's good. More positive findings on respect for patients' value and preference and express needs. Home visits again were the main thing that came out. They felt valued because we would go into their homes when they are really new in the country. And this is very important, I think, because during those 4 weeks, that's when most of the appointments are, and it's always in and out of their house, people asking them to go there, go here, and we go into their homes. So they found that really, really valuable. Clients expressed gratitude for refugee health program and use of interpreters. Information and education in language and pictures was found to be very helpful. Home visits allowed hands-on teaching. Again, it was highlighted on respect. Use of appropriate interpreters alleviates language barrier. Written information in primary language increases understanding. And these were some of the negative findings that came out. Top of the list was long waiting time to see GPs, even with appointment. This is an ongoing issue. Our clients, they are mostly very quiet. They don't like complaining and they don't like asking questions. So they'll just sit there until their name is called. And unfortunately, around areas like Warrawong, where there's a lot of people who use drug users, medical centers prefer to service those clients first for obvious reasons. So our clients sometimes can sit for much longer. And I know part of their reason would be their appointments are long, number one. Number two, they don't complain, unfortunately. Long wait time for public dental appointments for adults. This is an ongoing issue. Unsure how to make phone calls to access refugee health or their GP, and clients were unsure how to find health appointments at new locations. This happens mostly when they move on to their long-term accommodation, and then they move suburbs as well. Respect for patients' values, preference, and express. Some of the negatives were delay of healthcare professionals addressing concerns was one of the issues. GP and hospital staff not using healthcare interpreters appointments. I should highlight, even though our quality project was around finding out about our service, it's very confusing for our clients who is who, and not knowing whether we work with the hospital staff or not, it's one of the big issues. So some of the things that were coming up were not directly related to our service, but health as a general service, which I think is right because it's quite confusing for our clients. The negatives, continuing information and education. Verbal information overwhelming for clients when given in one session, especially during those 4 to 6 weeks. Written information given in an inappropriate language or to an illiterate client. Emotional support and alleviate of fear and anxiety lacking from staff, I think. Clients confused and anxious because they cannot identify healthcare professionals, which I said before. Families worried about residential options. Housing here has always been a problem. Discharge information from hospital not explained. I should say most of the negatives were not really from our service directly, but from other health service providers that are linked to health. And so we took all the comments into consideration, and we sat down as a team, and we came up with a planned strategy for improvement. So this is our plan. On access to care, arrange face-to-face clinic time during home visit where possible. So here we are talking about simple things like early childhood appointment or women's health appointment. If it's booked when you still have got the face-to-face interpreter and the client sitting next to you, they can actually say, tell you when they have another appointment. I should say the communication between us and our HSP provider is sometimes it really lacks. So we don't know when they have appointments and when they don't. So having them sitting with us face-to-face when we book appointments with other services is quite helpful. Explore options for decreasing waiting time with current GPs in program. So our families are normally huge families. So we've been talking to our GPs and practice managers and ask them if they can divide big families, 4 come today, the other 4 tomorrow, and to take appointments. If mom can bring the 3 kids in the morning, and then the case manager can pick up the rest of the family in the afternoon so that they are not sitting in the waiting room for 4 hours. And continue to research, to search for GPs to join the refugee health program. So how our program works down here is we've got a list of GPs that have said yes, we can see refugee clients. The main reason is because some GPs, they make our clients pay a co-payment on top of the Medicare card. And the other thing is they complain, some GPs complain that our clients' assessment take too long, and they might as well see local clients as they can see more clients in that time, even though they get paid for it. So we have got to go door knocking in practices, door to door, sitting down, making time with the GPs, explaining to them what we do. And then we ask them if they would like to join in the refugee health program. If they say yes, then we go and we do it like an in-service, you know, telling them about our service, what we do and what we expect from them, and the communication that should happen between our service and them. So this is an ongoing issue at the moment. We don't have too many GPs in on our books. And the other thing is with GPs from the Shohaven, which is quite far, it's really, really hard for us, which is where most of our Tibetan families resettle. It's really hard to get a GP who can bulk bill. So it's an ongoing process for us. And then also a GP who can speak the language, that will be added bonus. priority to GPs who speak primary language, which is an added bonus, and it's rare to come about in this area. Include GPs who are comfortable using interpreter services. This is one of our biggest issues, especially this year, because we've been getting quite a lot of minority languages. Even myself, I'm seeing some of the languages and minority groups that are coming this year for the first time. So it has been an ongoing issue trying to find interpreters. Some languages have got no accredited interpreters across the whole country. So for a GP to keep on cancelling appointments because there's no interpreter available, some of them will end up just proceeding with the appointment without an interpreter, which is not the best practice, but we have to keep on reminding them that we can always rebook. So the other thing is we try and register all our clients with the FICT program, which is the Families in Cultural Transition program run by STARS. And it's also run by community members from their cultures, which is really helpful. It's just about orientation to other families who live in Wollongong and what they can and what they cannot do, so that they don't get fines or they don't get in trouble with their with the law or even with their landlord. It has been working quite well with that program, or even simple things like where to buy culturally appropriate food. Community social events have been really helpful, and the main advantage is we have got the multicultural health promotion officers to help us with this. And we try and find them groups or services in first language, which doesn't come easy, but we try and form a group if there's a few people, if there's two families who speak the same language or are from the same background, we try and arrange for them to meet. Respect for patients' value, preference, and needs. We offer culturally sensitive training to GPs and hospital staff, and this is an ongoing initiative that we do. We try as much as do this mostly with hospital staff. We go to EDs, early childhood nurses mostly, and maternity services. Emphasize the use of healthcare interpreters. We do this almost on a daily basis. And I spoke about this already, about multiple shorter visits for big families on the information as well. It applies on the information if there's a lot to deliver on the first home visit. So we try and stay guides. Make sure that on the home visit, they know about 000, how to access the after hours GP, things that you really want them to know. And then we try and expand their knowledge on the second and third home visit. And sorry. And we also try and explore, even though they can't read and write, a lot of them, they've got WhatsApp, Facebook. So it means that they can use apps. So we try and orientate them to apps that are quite pictorial, like they can learn how to use to book their own GP online, which is quite good. Download maybe apps of pictures in their language, which we have found really, really helpful when they go around trying to communicate. Or download a picture of where they are going while it's at home, and then they can point to the picture and someone can help them. include more time for home visits, information sessions explaining refugee health services. This is an ongoing issue as well. It's really hard we try and give them as much information as we can, but we don't want to overload them as well. So staggering the information and remember the emotional support and anxiety that came up. We try and connect clients with a refugee health social worker, and we try and do more frequent home visits where it's possible and involve the families in decision making. And progress so far, this is what we have been doing. We are still doing exclusive home visits to all our families because we have realized this is the best practice for down here, and it's working really, really well. We always have to have 2 home visits for everyone. The first home visit, which is the initial home visit, and at least a follow-up appointment. So we have the initial home visit, 4 to 6 weeks follow-up. We have got a 3 months follow-up, which can be over the phone. And we also have got a 6 months follow-up, then we discharge them. So at discharge, we try and link up with the HSP provider and have the final home visit before we discharge our clients. And we also have a 7-day checklist routine that we do down here. So all our clients, we have gone paperless down here, which is really good. So for those who are from New South Wales, all our clients, they are registered on IPM, just like all the clients in New South Wales. And then when they are registered on our list of clients in EMR, which is the electronic medical records, every 1 day a week, we go through our client list to check if there's any of them we have been in contact with them, with the hospital, or they've got any appointment with early childhood or dental or any other services. We are able to see that and we can follow up. And this is as well where we do fault finding. It shouldn't be a fault finding mission, but we do it to improve the literacy of other services and also to improve the way that our clients are treated in the mainstream services by checking if interpreters were used and if the right interpreters were used. If not, we call the service, mostly ED, they know me quite well, because I would call them and ask them why an interpreter was used, and also remind them that it's a policy for them to use an interpreter, and it's the client's right for them to have an interpreter present. And we continue to advocate and educate our GPs and other services as well on the use of interpreters, and we give them tips and remind them that if you book an appointment, you have to send a reminder letter in their language, and also you need to remind the client of that appointment at least the day before, because they've got so many things happening in their lives. And we are involved with mostly with the University of Wollongong final year students, nursing, medical, and also social work students on the use of interpreters and refugees in general. And this has been really, really helpful for when they join us as new grads. So we are also running outreach programs in TEF and with the AMEP offices where they have their English classes. This has been going on really, really well. And we are involved in capacity building with clients through health education to improve health literacy, like the coaching model GROW. We run the GROW project 6 weeks every school term. And this year we've been doing it online because there's no face-to-face because of COVID. And we also try and value our clients' opinion from appointment dates and time and valuing their priorities and making sure that we are using the right language, even though they can speak 3 to 4 languages fluently. And we try and model the above to the other services to make sure that our clients have the best service wherever they go. This is one of the quotes from one of our clients that we interviewed. It really touched me. Even though we are refugees and have come from a difficult area in our country that has war and poor conditions, we can still recognize when we are treated well and when we are treated badly. We have feelings. We can tell when someone is treating us badly. If we wanted to be treated like that, we could have stayed in our country, but we fled from that ill treatment. We find it so strange that we find the same treatment here. We heard that Australia is the best, you know. That was one of our clients. So just to remind ourselves that and other services that we are health and we have to lead by example and we have to respect our clients. Thank you everyone for your time.
Thanks so much, Nyari. Some really very interesting information there, and yes, quite an interesting quote there at the end, isn't it? Now we're almost out of time, so I'm just wondering, is there any other questions? I can't see anything in the Q&A panel. I know that we only have a limited time here with our Zoom, so I'd like to, if there are no other questions, I'll just check that chat. No, okay. Going once, going twice, going 3 times, no other questions. All right, so thank you again to our 2 panelists, Nyari and Meryl and Nancy. Thank you to everybody who's listening and watching. Stay tuned for the presentation 3 of the Refugee Nurses Australian National Forum. That will be coming to you on the 14th of October with 2 new guest presenters, and look out for the flyer. So thank you again to our presenters and good afternoon.